So good afternoon, everybody. I came to Jabalpur in '98 when IACON was being held in Jabalpur, and I was a young, just getting out of MS and just started it, and the zeal and enthusiasm of Dr. Taki Raza, Professor Taki Raja was so much that even as a junior delegate, we felt that energy. And I went on to know him much more personally, and I've been as a part of Indian Orthopedic Executive from Kerala, and usually used to meet Professor Raza in IOCON's IOA meetings. And that, as you said, that he was always in a hurry, and it was always in a big amount of enthusiasm, not in a hurry, in a big amount of enthusiasm he always brought us. And it is a proud privilege for all of us to stand here in his name's oration. So this is my last talk, rheumatoid ankle. And once again, thank all the Olwa group for taking this topic into consideration and bringing all of us from different part of the country to get this topic of foot and ankle. The picture of washing the foot is actually a biblical story of Jesus washing the disciples' the feet. And that actually shows the humility which each one of us should have when we are examining the patient. And as the old age we've been taught is the dictum of clinical examination, this picture depicts the importance of clinical examinations. We have the MRIs, we have the ultrasound, we have the all sorts of spec CTs coming in, newer ways, robotics coming in, but I think we still have our clinical examination as a very important part. So talking about the rheumatoid arthritis, it's usually all of us know about rheumatoid arthritis in a major way. It's a medical problem, usually starts insidiously, smaller joints, more than the ankle. Actually it's the hand and feet that is involved, and the joints become warm. You know all the story, we have all learned about it in our MBBS days and MS, how we look at the rheumatoid arthritis. So it is the disability that creates problem to the patient, and those come to us as orthopedic surgeons. So it's the inflammation, the fatigue, and the problem of irreversible damages. So something which we should know is 90% of the joints are involved in the first year of rheumatoid arthritis. And that is the time you got to really treat. So once you see this patients in an early stage, you should treat, and there are so many medications now and to treat them early so as to prevent the disability of rheumatoid arthritis. Because if you don't treat it, then because of the lack of inadequate control, treatment, compliance, then you're going on to have a complete problem. So the goal is control the disease early so that we should not be treating the disability, because it's real bad disability. So you want to, why treat early? You want to prevent the joint damage, you want the disability to be prevented, and you want to decrease the mortality because of the disability. So the combination, there's this DMARD and different types. I normally don't treat the medical part of rheumatologist. I send it to my rheumatologist. They are better equipped, because we would not be doing justice with the medical management. I always believe it should be done by the rheumatologist, and DMRD does work very good with them, with those combination therapies, the triple therapy, the double therapy, and the newer generation biologics that has come in, which are actually very helpful and prevent and patient leads to near normal life. But when they don't take it or the compliance issue, then you have a disability problem of damage of both bones, cartilage, and they are not reversible. So coming to the rheumatoid disease in foot and ankle, is actually more than the ankle. It is the forefoot. It is the smaller joints that is affected first. Like the hands, the small joints are affected. So the toes, you have the hammer toes, you have the claw toes and all that. The hindfoot is affected is later on after the forefoot symptoms. So when you talk about hindfoot, involvement involves longer duration of diseases, and patient most of the time have a valgus deformity. So something which first session we had, I am going back again on the clinical examination, is every time you see the patient looks at the foot from the front. And we as doctors see the patient's foot from the front. One thing in clinical examination, if you want me to take home message, is ask your patient to turn around and look the foot from behind. And that is one important thing. The moment you start seeing the hind foot in varus, valgus, there is something wrong which will not be picked up when you see the patient from the front. So look at the patient from behind, and most of the time you'll find a valgus deformity there. So rheumatoid arthritis, the deformities are quite severe in hindfoot and ankle. It can be from any part, the tibiotalo-calcaneal, all the joints, or a tibiocalcaneal, or a complete pantalar problem would be there. So here is one of my patients who came with a severe pain, a farmer, manual laborer, on irregular treatment, and severe pain on ankle. Now you can see a large cyst, huge cyst here, but it was not so deformed, but he was a manual laborer, so I decided on arthroscopic fusion. So you can see the amount of, the moment you put the scope, you can see the amount of destruction that is inside the cartilage. The whole synovium, the pannus formation type, it's completely destroyed ankle joint when you scope it. And it takes a good amount of time to shave off when you're doing arthroscopically, but it heals well, so it is worth the time when you do an arthroscopic fusion. But so this is what it is. It is a completely destroyed ankle here. And here you can see my, see that is that huge cyst which we saw in the X-ray. You can, and that's the curette going into the cyst and curetting it out the cyst. So that is how you do it, clean it up completely, and then fuse it, and then it goes on to heal. So this is the simplest thing which you can do in a rheumatoid arthritis, an arthroscopic assisted fusion, provided the position of the ankle is in a reasonable position. It's not deformed. Arthroscopically, you can do this. But when you have a severe case, this is Dr. Rajiv Shah's case, and this is how it is. It is completely destroyed. Pantalar area, you can see, this is what I was saying, look the patient from behind, and you can see the amount of valgus problems. Look at the x-rays. The subtalar arthritis is already done, but ankle now is creating a completely major issues, complete destruction, and this is what was done, and the patient goes on to heal well. This is a case 3. Now this was much more prevalent, again Dr. Rajiv Shah's case, rheumatoid arthritis with an osteomyelitis of the calcaneum. It seems he had given the option of amputation versus 2-stage surgery. Patient took on the 2-stage surgery, and this was the x-rays. Half of the calcaneum is not seen, but then as Pradeep was mentioning, you can get away with a little bit of calcaneum. You don't need a full calcaneum. So Dr. Rajiv Shah did the same. He went and explored the wound, did put in some stimulant here, and the wound started healing. And once the wound healed, he did this pantalar arthrodesis. So this is how the final look was, and the limb seems to be reasonably okay. I don't know how much long follow-up he has. I have no 2-year follow-up, sir? Yeah, so that means the surgery has done its work, and the patient, he has salvaged the limb. So you can do something like that, but the ideal thing is you don't want to have such an amount of problem if you can treat this patient early. More than the ankle, though this topic was about the rheumatoid ankle, I thought I'll just show one of the patients which I had is a rheumatoid foot. Rheumatoid foot is much more commoner than a rheumatoid ankle. And when you have this type of ankle, you can actually get the whole thing corrected. Look at that particular thing. This lady has been having this ulcer for more than 1.5 to 2 years, being treated as corns, calluses, multiple debridements, but it was actually the subluxated second metatarsal which was creating the problem. So you just have to correct the axis, did a fusion, and look at this final end results. Such a difference between a pre-op picture of the first picture and the final when the wounds have healed. The patient gets back near normal foot and completely painless foot. So there are good things that can be done with foot, provided you understand the biomechanics and don't treat this as the corns or calluses. You have to understand that this is subluxated metatarsophalangeal joint which is creating the problem, and you got to treat the subluxation and not the ulcer. So in conclusion, treat rheumatoid first with medications at the early stage and avoid destruction. Salvage possible, not many a times, but yes, possible many a times, and arthrodesis. And soon we'll have the arthroplasty, so probably in few years' time we can show some plasty patients post rheumatoid arthritis. Thank you very much. It was wonderful coming here.